I have come up with the remaining part of my lecture on blood component therapy, and here it is. I'm starting. Complications of transfusion, that is human error, number one. Complications due to human error are significantly more common than transfusion related infections. In order to prevent errors, it is critical that all persons involved in administering the blood products exercise extreme caution. Acute hemolytic reactions. The most serious complication of blood product administration is acute hemolytic reaction, usually caused by ABO incompatibility resulting in an immune reaction by the recipient to the transfused RBC. Signs and symptoms of acute hemolytic reaction: anxiety, fever, urticaria, hypotension, hyperkalemia, nausea, chest and flank pain, hemoglobinemia, and acute renal failure. Many symptoms are masked by the general anesthesia. This is very, very important. If you suspect an acute hemolytic reaction, immediately stop the transfusion. Begin supportive care, which includes BP support with pressures and inotropes as needed. Preservation of atrial function, preservation of renal function with fluid administration and diuresis. Alkalize the urine with soda bicarb. Obtain urine and plasma hemoglobin, antibody screen, coagulation parameters, and blood count. Delayed hemolytic reaction caused by extravascular hemolysis of donor erythrocytes due to the presence of antibodies from previous transfusions or pregnancy in recipient serum at levels too low to be detected during the cross match. So this is important. It may not detect it in the cross match, but it can manifest itself by delayed hemolytic reaction. Signs and symptoms of delayed transfusion reaction occur approximately 1 week after a seemingly compatible transfusion. After 1 week, एक हफ्ता हो गया, उसका बाद आपका hemolytic reactions are manifesting them. These include anemia, mild fever, increased unconjugated bilirubin, jaundice, hemoglobinuria, decreased haptoglobin, and spherocytosis on the blood smear. Because the hemolysis is extravascular, the reaction is much less severe than in an acute hemolytic reaction, and the symptoms are self-limited. Now we come to trali. Trali. What is that? transfusion-related acute lung injury. An acute respiratory distress syndrome, ARDS, occurring within 2 to 6 hours after the transfusion, characterized by non-cardiogenic pulmonary edema manifesting as hypoxia and bilateral infiltrates in the chest radiograph. Its true incidence is unknown because it is difficult to distinguish from other forms of acute lung injury, and it often occurs in patients with multiple coexisting diseases. TRALI is not rare. Its estimated occurrence is 1 in 2,000 to 1 in 5,000 transfusions of blood or blood products. So, TRALI is a leading cause of death from transfusion in the United States. Treatment: supportive care with most patients require mechanical ventilation. Small tidal volumes are recommended. Hypotension is generally responsive to IV fluid. Despite the presence of pulmonary edema, diuretic administration can worsen the patient's condition. Infectious risks: bacterial contamination. Bacterial contamination of blood products is most common with platelets because platelets are stored at room temperature. The most frequent contaminating organism is Yersinia enterocolitica for RBC and Staph aureus for platelets. Suspect bacterial contamination and consider antibiotic therapy in patients who develop a fever within 6 hours after the platelet transfusion. Viral transmission. The incidence of viral transmission has increased substantially over the past 20 years. Now, the human acquired deficiency virus, which is most dreaded, AIDS, this is 1 in 2 lakh transfusions and 1 in 16 lakh transfusions for hepatitis C virus. Other viral pathogens that can be transmitted are cytomegalovirus, human T lymphotropic virus, etc. Other potentially transmissible infectious diseases include malaria, Chagas disease, etc. Now, summary for the blood component therapy. Blood component indication guidelines and complications warnings. Like PRBC, increased oxygenation capacity, almost always indicated for hemoglobin less than 6. Almost always not indicated with hemoglobin more than 10. 1 unit of PRBC increase hematocrit by 3%, hemoglobin by 1 gram. Warm blood, ABO compatibility essential. FFP, that is plasma, here the plasma clotting factors. Treatment of microvascular bleeding in the setting of coagulopathy, that is INR, more than 2 APTT 2 times normal. Reversal of specific agents such as warfarin for trauma. Evidence supports earlier FFP administration. Suppose you have to take a case of trauma for anesthesia. So in that case, you may have to give this FFP to decrease the bleeding. May require time to thaw, means warming, ABO compatibility essential, cryoprecipitate, factor 8 and fibrinogen. Treatment of fibrinogen deficiency usually less than 80 to 100 mg per deciliter. When the fibrinogen falls down so much, only used in the setting of DIC. Platelets, treatment of severe thrombocytopenia in the setting of bleeding, surgery or platelet destruction. Usually not required with platelet count more than 1 lakh. Usually given for platelets less than 50,000 cells per cubic millimeter, especially in surgical patients. Single donor should be most common in platelet cases. Potential for bacterial contaminations. Thank you. This is the end of my lecture.